functional radiation medicine, MR and CT adaptive radiotherapy, and protons. Plus, why Dr. Christodouleas thinks he's got the best job in the world.
Dr. John Christodouleas is Senior Vice President of Medical Affairs and Clinical Research at Elekta. He's also an internationally recognised radiation oncologist specialising in prostate and bladder cancer. Nationally, he's an authority on image-guided proton therapy and intensely modulated radiotherapy, with numerous publications and over 20 book chapters to his name. John has led research initiatives at the University of Pennsylvania, reviewed for major oncology journals, and co-edited a leading radiation oncology textbook. Currently, he is advancing MR-guided radiation therapy as co-primary investigator of the global MOMENTUM study, an international effort to optimise MR-Linac treatments for patients worldwide.
Welcome to this episode of Spilling the RT. I'm your host, Emily Bassett.
You've boldly remarked before that one day all treatments will be adaptive. Would you bet your house on that?
Well, what do you think, Emily? Just knowing what you know.
I think, yes, I agree. I think certainly there will be the option for them to be adaptive. A lot of people would say, well, not all treatments need to be adaptive, but adaptive is a natural evolution of precision radiotherapy. Like, it seems like a natural next step. That like all SBRT treatments would absorb adaptive. Yeah,
I think that statement that I sort of make, I start often a lot of presentations with that statement that in the future, I put in parentheses almost all fractions will be, exactly, giving myself the out. No, I think if that statement sounds provocative, but if you think about it for a few minutes, it's obviously true. That when you see how the technology is evolving, the auto segmentation is getting so fast and so good. I mean, literally can be, done in seconds, and it's so much better than what we can do as humans and so much faster. The replanning times are coming down with, these new fancy GPU chips that everybody's going crazy about from NVIDIA. They're coming, the plans can be re-optimized so quickly in less than a minute. It's hard to imagine, A, that trend isn't going to continue. And that B, as a, self-respecting, radiation professional, you wouldn't want to re-optimize the plan if it's literally a couple minutes extra. Frankly, we're already seeing that. We see that. I was visiting a clinic in Berlin, and they're actually one of the first sites with Evo Online Adaptive, which is the CT platform. And they can transition from a non-adaptive treatment to an adaptive one, within seconds, and actually adopt a plan and add maybe additional 4 minutes to their treatment, right? We saw that in person, right? They had a 15-minute slot. There was a big change in a post-prostatectomy case. The anatomy was very different. They decided to adapt. 4 minutes later, they were delivering a new updated plan, right? And 4 minutes is already where the technology is in terms of being able to allow clinics to adjust their strategy. And it's just going to get faster and faster. And so I think it's just going to be the default strategy that we will do adaptive unless there is some weird reason not to.
Yeah, and you just mentioned Elekta, Evo, and I was going to ask you about the sort of how Elekta's evolving adaptive to include CT-Linacs. But I think what you're saying is really important, and I guess the point I was trying to make is that the environment Elekta One is enabling the opportunity, but still giving that flexibility to also treat these high, volumes of patients or whatever the clinic needs to do at the moment.
Yeah, absolutely. I mean, I think the way that I think about it is we know where the future is, right? We know that in the future, we'll want to adapt almost every fraction. Mm-hmm. We know that is not the present. Most clinics are not adapting, a large percentage of their patients or they're fractions, right? They're adapting a small subset.
Yeah.
But over time, that's going to get more and more and more. And what we have focused on with the Elekta One portfolio, our Elekta One planning offline, our Elekta One online planning system, and the OIS, the Elekta One OIS system, is to make that future possible as easily as possible. So centers can start adapting at their own rhythm. That's sort of the catchphrase we have been using within the team, adapt at your own rhythm, because, again, as it gets easier, we want to make it as easy as possible to do what you think is best for patients. And I think Elekta One ecosystem is a major step forward for us in that long-term strategy of making adaptive as easy as possible.
Yeah, and I think the rhythm also applies to CT and MR as well. So obviously, Elekta is offering both of those modalities. So, centers finding their own rhythm and how they apply the imaging technology for certain patients.
Yeah, exactly. And an underappreciated, if I just emphasize just part of this story, an underappreciated aspect, I think, of the Elekta One environment is how it's enabling remote collaboration.
Okay.
At the end of the day, doctors need to be in clinic seeing patients, right? And so we are working very hard to create tools for remote collaboration. So there isn't a necessity for a physician to go to the machine, though, of course, that's always an option, and clinics may choose that workflow, but we don't want that to be a requirement, because then that will just be an obstacle towards the adoption of the highest quality of care, which is going to be adaptive therapy.
Yeah, and that adoption is partly obviously based on the clinical evidence that can be provided by these teams that are working very hard to research. Can you comment on the some specific cancers or patients where adaptive has been shown to be particularly beneficial so far? I feel like we've got a mountain of evidence for Elekta Unity.
Yeah. Well, it's really important when we talk about sort of our adaptive future to separate the world into CT adaptive and MR adaptive, because they are different IGRT tools. Mm-hmm. And something very important is happening in radiotherapy, and we are becoming a multimodality IGRT specialty, right? And the other fields, interventional radiology, diagnostic radiology, et cetera, have been multi-imaging, multi-modality IGRT specialists for a long time. But we are now starting to develop sort of practices that are most appropriate with CT guidance and practices that are most appropriate with MR guidance. And I see us evolving into a specialty that simply places patients in the most appropriate device. And I think that, again, in the future, most moderate-sized radiotherapy departments will have CT and MR Linacs both, and they will be choosing the device that is most appropriate based on the disease and the imaging that is best suited towards that disease. So with that background, there's lots of compelling evidence for adaptive for glioblastoma, and the most important studies that have been published, I think there are two that I like to highlight in particular, and that is the United study that was led by Sunnybrook Hospital, which was presented at the plenary session of last year's ASTRO, where they showed very compelling evidence that you can actually shrink the uncertainty margins without causing excess failures in glioblastoma. And it was a dramatic shrinkage of the uncertainty margins. And and to me, that's exactly what that's the the whole point of adaptive is to minimize uncertainty in your targeting and spare normal tissue and or intensify treatment. Even sort of more provocative was where UT Southwestern has taken glioblastoma, and they are starting to treat very small margins for glioblastoma in 5 fractions. Now, 5 fractions has been studied before, but people are nervous about it because glioblastomas are changing shape, and they often can be large, and there can be bisensitive structures in the brain. But UT Southwestern has adopted a adaptive strategy, an online adaptive strategy with Unity to treat patients very safely and very efficiently, at least based on their most recent study from 2025. And the senior author there is Dr. Wardak from UT Southwestern, who's been leading that program. So brain is a great example of something that is likely going to be MR adaptive therapy, because it's hard to imagine that we're going to get a lot of information from CT adaptive.
Do you think that could ever be PTV free?
Well, in the UT Southwestern paradigm, there is no PT. They do not put a PTV. Is. Yeah, it's already PTV free on the GTV, which is the T1 post-contrast enhancing volume. They don't put a PTV on it. There is a lower dose volume around the GTV using the FLAIR imaging, but they don't put a volume on that high dose bath.
Adaptive radiotherapy, or ART. Radiotherapy has long been a cornerstone of cancer treatment. But what if it could be even smarter and more personalised every single day? Every patient is different, and so is their anatomy, which can change daily due to tumour shrinkage, weight loss, or organ motion. Traditional radiotherapy plans, which are designed to take the patient through all the treatment fractions, can't always keep up. Adaptive radiotherapy, or ART, can respond to these changes. Using high-quality imaging like MRI and advanced cone beam CT, clinicians can visualise the tumour and surrounding organs before each session. Adaptation can happen while the patient is on the table, called online ART, or between sessions, known as offline ART. Both approaches ensure treatment stays on target. Today, AI and automation are accelerating this evolution to do things like enhance imaging and help clinicians replan in minutes or seconds instead of hours. Clinical trials are starting to show the benefits: reduced side effects, improved local control, and fewer treatment sessions. With cancer cases expected to rise to 35 million annually by 2050, adaptive radiotherapy helps clinics do more with less, enabling hyperfractionated regimes and treating complex cases with confidence. Adaptive radiotherapy sets forward a path to new standards of care. Scalability globally is not just dependent on technology, but things like changes to reimbursement models. Personalised, precise, and scalable, it may transform how we care for patients. ASTRO 2025 just wrapped up in San Francisco. Yeah. Can I ask you for some reflections on research that was presented there? So maybe starting with the theme this year, which included expanding indications for radiotherapy.
This year's president of ASTRO, Dr. Samir Kaoli, made functional or non-malignant radiation medicine a major theme of the year and also this show. And I actually think, I don't know if it was serendipity or it was something that they called for, but one of the most important abstracts that was presented was on functional or non-malignant radiation medicine for osteoarthritis of the knee. So this study by Dr. Kim and colleagues from Seoul, Korea, was looking at low-dose radiation given in 6 sessions, so 3 gray total, which in radiotherapy, as you know, of course, since the audience may not know, is a very low dose bit of radiation. And it's sort of surprising that it does anything at all to those of us who are used to treating tumors.
Yeah.
But what they found is that these patients who have sort of moderate osteoarthritis of the knee or sort of knee discomfort, they improved. They had significantly improved outcomes by their own report 4 months after being treated with low dose therapy compared to sort of placebo or fake radiation therapy. If we, as a field, sort of adopt this radiation medicine ethos, the number of patients that we might be eligible for our care would approximately double, at least based on what's happening in Germany, where this has been already embraced. So it's a hugely important study, and it was given a major platform at ASTRO, and that was really exciting to see.
As you know, we had Dr. Bobby Canero on the podcast in the last episode, and yeah, it's great to see the evidence coming out of something like ASTRO. If I may ask you about proton therapy and the evolution of proton therapy. So I actually wrote prior to ASTRO that proton research was trending upwards. I quoted a recent study from out of MD Anderson, which suggested toxicity improvements and finally beginning to show differentiation for outcomes. But at ASTRO, would you say there was a setback to that? I know there was a lot of social media around the Torpedo trial and commentary. Yeah. What's your take on that, John?
Well, just to immediately comment on Torpedo and that particular indication. So what they were studying in that trial was proton therapy for radiation of the oropharynx, the head and neck, a very common tumor in the West.
Yeah.
They found in that study essentially no differences between high-quality IMRT and high-quality proton therapy. That's sort of the high-level one-liner. And, that you sort of alluded to a prior study from MD Anderson. And actually, the results, as I understand it, between the two studies are quite similar. It's just that the MD Anderson study had a surprising finding. After 3 years of follow-up, it looked like the survival curves were separating for reasons that people debate, whether it be sort of late effects of X-ray based radiation, or is it simply something having to do with biases that creep into studies when patients drop out. So in the MD Anderson study, a lot of patients, and actually the majority of patients, had already dropped out of the study or were censored from the study by the time the curves started to separate. So the enthusiasm from that MD Anderson study is a little bit dampened by the results of the Torpedo study. So the journey for proton therapy in head and neck cancers continue. But if I might provide just a little bit of editorializing about proton therapy in our field. As you know, Emily, it's quite controversial.
Yeah.
Protons in general.
Provocative, I would say, on platforms like Twitter, and people are reactive to it, I would say.
Yeah, exactly. And that's in part because it is expensive. It's an expensive technology, and it's sort of so expensive that it would, if proton therapy is important, it would have dramatic implications for how we set up radiotherapy in our field. But I guess I would say, as someone who works at a large proton center, and as someone who works also in industry and sort of knows the very acutely aware of the access issues of radiotherapy. I think two things can be true. One is we really want our field to be working on proton therapy. We want as many tools for our professionals in radiotherapy, because that only strengthens us as an industry, as a profession. But we also have to take very seriously, our responsibility to use healthcare resources judiciously. And I just think that despite all of the sort of controversy, drama around proton studies, particularly as it manifests in social media, I think as a field, we're doing an amazing job. It's really hard to study big technologies that require huge upfront investments. And if you sort of look at what we have done as a field in terms of the rigorous studies that have happened across different diseases, prostate, breast, head and neck cancer, lung, esophageal, et cetera, I think we're doing exactly what we should be doing at the end of the day. There's all this debate, which is exactly what should be happening. But at the end of the day, I'm very proud of our field for the work that we are doing in evaluating, a potentially important technology.
Speaking of big technology, we heard somewhat about the clinical impact of MR adaptive radiotherapy for prostate cancer at ASTRO as well. So can you give us your thoughts on the patient-reported outcomes from Dr. William Hall's cohort study, and particularly your sort of take as someone who treats prostate and bladder patients?
Yeah. So this was a really interesting study from the MR-Linac consortium, the Momentum project in particular. And this study was looking at patient-reported outcomes for prostate cancer patients who were treated using two different workflows on Unity, Elekta's MR-Linac. And in one workflow, patients' anatomy, particularly the prostate and the target, is contoured every day and adjusted every day. And in the other workflow, it's not. We just, in that workflow, you just adjust for the position of the target. But if there are shape changes to the bladder, rectum, or prostate, or seminal vesicles, you don't account for them in that workflow. So it was sort of daily recontouring versus not daily recontouring. And the headline of that study was that daily recontouring is associated with improvement in urinary toxicity, in urinary bother scores from these patients, but not in, there wasn't evidence that daily recontouring was associated with improvements in rectal or sexual dysfunction. And so that's a little bit counterintuitive unless you sort of dig into the data. And the underlying rationale or hypothesis is that the prostate is changing shape during therapy. And actually the most interesting part of Dr. Hall's presentation, at least to me, was that he showed really compelling evidence that the prostate is changing shape and in non-symmetric ways. And that can disrupt the dosimetry of a radiation plan, which can potentially lead to hot spots in the urethra. And then there's actually prior evidence, prior studies by the Royal Marsden that shows that to be true. So I think that it's a very compelling study, and for both of those reasons, that the outcomes were improved with daily recontouring, but maybe more important for everyone, even if they don't have a Unity, is that the prostate is really changing shape, and sometimes in dramatic ways. So we have to be very, very careful when we shrink our margins, particularly when the dominant, tumors within the prostate, we call them the dominant intraprostatic lesions, when they are at the edge, particularly the superior and inferior edges of the prostate, because we take a risk of missing. So it was a great study and very well presented. And I think it will generate lots of discussion particularly when people see the papers and they can see those deformation analyses.
Yeah, and maybe important to point out that it was, I think, 12 centres altogether that were involved in the trial across the consortium as well. So
that's right.
Not just North America, but across Europe as well.
Absolutely. And, it in and of itself, I think I'm just very proud of the achievement. These centers have been working together for years in aggregating data, and now we have tons of data to evaluate.
Can you tell us about the most recent addition to the medical affairs team? I hear she's a four-legged fairy friend.
Yes, it's a sensitive issue because we have a new puppy which is causing great joy, but also great frustration because the puppy keeps using our house as a restroom. And that's the new addition to the medical affairs team. Is our furry friend, who sometimes is not a friend.
It knows that you're a specialist in urology, so yeah,
Yes.
It's
I
a
think
she.
that's what's happened.
It's a she. I'm saying he.
She.
It's a she. Yeah.
Yes.
Yeah, I've got a puppy who's now a year old, so I can sympathise. We're well over that state. It does get.
Yeah.
I know everyone will say
Does
that
it
to
get
you.
better?
It does get easier.
Yeah. Yes.
Yeah.
We've had dogs. We've had a dog before, but not a puppy. And this is
It's intense.
more exciting and challenging than I expected.
But the best sort of person I find in the house to come home to is definitely the dog. You know, you've been away on a trip or something.
Yeah.
The greeting.
I won't say that to my kids. Is this being recorded?
Yeah, they won't see it. They won't.
You're right. They won't see it.
And then finally, John, if I could ask you, if you could pick one, is there one thing you could say is the best thing about your job?
Wow. So the one thing I think what I want to say is that I have the best job in the world. And I know everybody says that.
I don't think everyone says that.
Lots of people say that, but they are wrong. I actually do have the best job in the world. And particularly the balance that I have where I get to be in a fantastic clinic and work with fantastic colleagues in the hospital, but also work with amazing colleagues at Elekta on something that we think is really, really important. So the best part of my job is that I get to work on things that I think are important with people that I think are amazing. So in one line. And I sort of pinch myself all the time thinking about how blessed I am to have the gig that I have.
It's so nice to hear you say that, and it's such a big part of your life, isn't it? Whatever your job is,
Yeah.
That to feel like that, I think it is quite special.
Yeah.
So
No,
yeah.
It is. I feel very, very lucky, for sure.
Okay,
Yeah.
so I think that just about wraps us up. So thank you. It's been so good to get a decent amount of time to pick your brain. It's been
Good
great.
chatting with you, Emily.
If you enjoyed today's episode, then don't forget to like and subscribe wherever it is on your screen, and tune in for the next episode.